Okay, so let's start. Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Society of Medical University of Sevilla in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Sevilla 2024. My name is Victoria Štipka, and it is my pleasure to coordinate an otology and pediatric session. I would like to cordially welcome the esteemed jury. President of the jury, Professor Przemysława Jarosz-Kobot, and Professor Iwona Marunia-Klinczek.
Hello, nice to meet you. Nice to see you.
Okay, so we would like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book, with one exception. Work 7th will be presented last. Dear jury, please keep this in mind when filling out the assessment cards. I will try to remind you about this again during the session. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move to the conclusions and finish the presentation as soon as possible. We will show you the passing of time on the screen of a laptop standing on the desk. Esteemed jury, I would like to kindly remind you that if you are a supervisor of the paper which is presented, you should not assess the work. In the case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. All the presentations and the discussion must be run in English. If the commission will ask the question in Polish, the authors of the work are obligated to answer in English. Dear jury, we kindly ask to assess scientific value, way of presenting, discussion, and own contribution. When the session ends, we kindly ask you to give the cards back to the coordinator. And to begin, the first presentation will be evaluation of peripheral blood smears in patient with sepsis in comparison with biochemical parameters, presented by Karolina Nowak.
Good morning. My name is Karolina. I'm a student of Medical University of Warsaw, and I have a pleasure to present to all of you the results of my research concerning the evaluation of peripheral blood smears in patients with sepsis in comparison with biochemical parameters. Okay, so to start, the sepsis is generally an excessive inflammatory reaction, excessive systemic inflammatory reaction caused by the presence of pathogenic bacteria in blood. As it develops, it basically gets out of body's control and can cause a very serious damage, for example, because of the occurrence of cytokine storm. That all actually can also easily lead to death of the patient because of multi-organ failure. Unfortunately, the symptoms are not very specific, as you can see, so it isn't very easy to diagnose such patients. Traditionally, if we want to be sure that we are dealing with bacterial infection in blood, we have to perform a blood culture. But traditional blood culture actually takes a lot of time because it is about 2 days to have the final result and the identification of bacteria that caused such infection. It is a lot of time considering that very small patient, a child can easily die because of cytokine storm. And that's the reason why in diagnostics we very often use C-reactive protein and procalcitonin. But in this specific situation, procalcitonin is a better choice because procalcitonin level, unlike C-reactive protein level, rises specifically in bacterial infection, not just in any other inflammatory. So knowing all of that, we decided to check if measuring the procalcitonin level can give us some more information comparing the data with the blood smears. And we wanted to determine the correlation between the procalcitonin concentration and changes that occur in neutrophils in morphology. So material and methods. The study included 36 patients, 18 boys and 18 girls. First step was to actually measure the procalcitonin concentration and perform the complete blood count. We used the value 0.5 nanogram per milliliter as the criteria for qualification for the study because it is basically a cutoff point to decide if we are dealing with a sepsis or maybe it is just a local bacterial infection. So the second part of the study was to do blood smears manually from the blood that remained from complete blood count and count all the cells or 100. It depends how much cells there is. The results were as follows. So the main result of the study was to see that actually almost 78% of blood smears that we've seen contained neutrophils with blended morphology. Here is the picture of some neutrophils that we've seen. You can see that with the arrows I pointed at the such morphological alterations, vacuoles, toxic granules, and deformed nucleus. Next part of the results. In 7 out of 36 smears, percentage of normal neutrophils was higher than the altered ones, and that's not a very promising result. Here is a bit different neutrophil. You can see that the granules are actually polarly arranged at this part. And the next part of the results, in 60% of patients with procalcitonin level over 9 nanograms per milliliter, neutrophils with toxic granules constitute more than 50% of all the leukocytes in blood smears. So moving on to the conclusions, we noticed that there is actually a relationship between the presence of morphologically altered neutrophils and bacteria and bacterial infections, but direct correlation between neutrophils morphology and procalcitonin concentration remains ambiguous and most likely depends on many different factors that should be further analyzed. And that's all from me. Thank you for your attention.
Okay, thank you for your presentation. And Sindri, do you have any questions?
If I can, I would like to ask, what was the age of the youngest patient in your study group?
The youngest patient had a few months, but I am not actually sure how old he was, but it was a few months.
It's okay, but it was not a newborn baby in the first days of life.
No, definitely.
Because there's a particular curve of procalcitonin in this period of time. Okay, and these patients were diagnosed with sepsis based on blood culture or based on clinical conditions?
Actually, we connected. We reached to the other clinic, the laboratory in the same hospital, and we confirmed that these patients actually were diagnosed with sepsis.
Were diagnosed with sepsis. Okay, thank you.
Thank you very much.
Do you have any other question? Yeah. Okay, so thank you for your presentation. Congratulations. Okay, and now it's time to the second work, which will be presented by Magdalena Mida. The title is Assessment of the Acceptance of the CDAD Diet by Children with Crohn's Disease and Their Parents. I would like to extend a warm welcome to all those present. My name is Magdalena Mida. Together with Urszula Majda, we prepared a study titled Assessment of the Acceptance of the CDAD Diet by Children with Crohn's Disease and Their Parents. Crohn's disease is a full-blown inflammatory disorder that can affect any part of gastrointestinal tract. The etiology of disease remains unknown, although environmental factors that modify the gut microbiota, including diet, play an important role. Based on data from the National Health Fund, 23,574 patients with Crohn's disease were identified in Poland between 2009 and 2020, including 1,730 patients, children, and teenagers aged 0 to 19. Treatment modalities include general recommendations, avoidance of exacerbation triggers, pharmacological treatment, and nutritional treatment. Nutritional treatment is employed as the initial therapeutic approach in the induction of remission in children. The Crohn's disease exclusion diet comprises two induction phases and third, maintenance phase. The dietary regimen, when combined partial and enteral nutrition, has demonstrated efficacy of the induction remission in children. In first and second stages, it is recommended that individuals consume full-value protein with low taurine content, soluble fiber, resistant starch, and unsaturated fats on a daily basis in order to ensure that their nutritional intake is adequate. An essential aspect of the dietary regimen is avoidance or minimization of dietary factors that they may exert a detrimental influence on the pathogenesis and course of disease. Each patient has access to the application with ready-made recipes compliant with CDAD diet. Patients can find a consultant worldwide using the Model Life program website. The aim of our work was evaluated to acceptance of the CDAD diet by children with Crohn's disease and their parents. The data were collected using an original questionnaire specifically for the purpose of study and approved by the ethics committee. The data were collected between April 2022 to April 2024. The study included 40 children with Crohn's disease aged 7 to 18 and 54 parents. We have started cooperation with the Department of Gastroenterology and Pediatrics, the Upper Silesian Children's Health Center, named after St. John Paul II in Katowice, and also with Polish Association for the Support of People with Inflammatory Bowel Disease, JELITA. We participated in organization meeting where we were able to distribute the questionnaire. The questionnaire link also appeared on the organization Facebook page. All respondents reported an improvement in their health since they're implementing the CDAD diet. Most patients accepted the diet, although some patients needed more time. Parents have reported a problem with their children's strict adherence to the diet. Only 22.5% of CDAD diet patients strictly adhered to the CDAD diet. The utilization of CDAD diet products by patients' family members was also evaluated. A total of 39% of parents survived indicated they had chosen of CDAD diet products. the parents cite the following reasons for their decision to provide the support of children, and that their diet was healthy. In the question about consulting with the dietitian, 61% of parents declared that they did consult with the dietitian. The remaining 39% of parents cited financial reasons, having sufficient knowledge and difficulty finding a dietitian familiar with the diet as reason for not consulting. Also, the majority of parents use particular applications. Half of adults say that the diet are more expensive. 55% of parents also noticed that they need more time to prepare meals from the CDED diet compared to the previous diet. 57.5% of children admitted that they had to give up going to restaurants due to their diet. Also, 35% were forced to give up going to school trips. It wasn't a problem only for the child. 57% of parents also admitted that they do not go to restaurants due to the child diet. 44% of patients admitted that their diet affects of their psyche and behavior. Some of them also experience resultants from peers. We asked parents what they find the most challenging regarding the child's diet. Among the responses were the price of the products, availability of products, the absence of control over the child's diet at school, and having to stop going out to restaurants with child. Most patients accepted the diet, although some patients needed more time. Patients benefit from the support of the dietitians and special applications. Children experience rejection from the peers and ridicule, which points to the need for greater social education. One of the biggest problems for parents is the lack of a control what the child eats outside and home and giving up going to restaurants. Thank you for your presentation, and now it's time to discuss. Any question?
I have a question about how many participants will involve in the study.
We have 40 children, aged 7 to 18, and 54 parents.
Okay, and the age was from 1 to 18, yes?
Now our children have 7 to 18.
7 to 18, okay, because you have the small kids and just teenagers, yes?
Yes.
It's a completely different group. So for me, when you will divide these age groups, you will have smaller amount of study group from the youngest and from the oldest. So they have completely different challenges, if I can say like that. Yes, for example, small children, of course, they need the care from the caregivers, parents, and so on. But the teenagers, I think nobody wants when it's 18 that somebody will go with, the mom will go with him or with her. So maybe you should divide into two, at least two age groups, you know, this study group. That's my thought.
Thank you. And our meet online.
I do understand that you have contacted all the parents and children personally, haven't you?
Yes, we personally gave them our questionnaires.
Okay. And maybe I omitted that, but what was the period of time they had to be on a diet and stick to the diet? It was a certain period of time, or was I don't understand, it was a continuous process being on a diet?
Yes, we don't have any criteria for this, that children had to be on diet in some period of time. It also must be only the diet.
Do you think? Okay, thank you. Do you think that the education of these children and the education of the parents were sufficient? Do you think that something could be done more to educate them and to convince them to stick to the diet?
You mean children, yeah?
Yes.
I think it will be good, maybe some meetings on schools with psychologists and talking with children that being on diet and having a disease is not something that children should reduce resistance.
Thank you very much. Thank you.
Okay, thank you for your presentation. Congratulations. And now I would like to ask to present the third paper, exercise related hypoglycemia in children with type 1 diabetes mellitus by Jakub Mengel.
Thank you very much. Good afternoon. My name is Jakub Mengel, and together with Ania Matusik, under the tutelage of amazing doctor, we have prepared a presentation about exercise-related hypoglycemia in children with type 1 diabetes mellitus. Physical activity is very important generally, but especially so when it comes to management of type 1 diabetes. It has numerous advantages, which we have listed here, and I'd like to highlight two of them. Improved insulin sensitivity and extended remission time in children with new onset of diabetes mellitus. The recommended amount of exercise is 60 minutes per day of moderate to vigorous intensity, primarily aerobic, physical activity across the week. And it's important to know that there are types of physical activity and they affect glycemia differently. Aerobic activity such as swimming or running, it tends to lower the glycemia, and anaerobic activity, powerlifting or sprinting, it generally increases the glycemia. So hypoglycemia usually is connected to aerobic activity. And now a few words about the main villain here, hypoglycemia. Why is it so significant to prevent and or manage hypoglycemia correctly? It's important because of its impact on the nervous system. Repeated episodes of hypoglycemia cause permanent cognitive impairments, and children are especially prone to this because their brain is still in development. The aim of our study was to estimate the incidence of exercise-related hypoglycemia in children with type 1 diabetes and to identify methods to reduce the risk of it correctly. To accomplish this, we have used a survey based on newest ESPAD guidelines. Our study group consisted of 30 children, 16 of them were females and 14 males. Average age was 14 years, and on average they have had the diabetes for about 8 years. Can you go back? 77% of our group used personal insulin pump, and the rest used multiple insulin injections. All of the respondents used real-time continuous glucose monitoring. We have tested the children on knowledge of recommended amount of physical activity, and unfortunately only 20% of them knew the correct answer. Around 57% of the respondents always participate in physical education, And on average, physical education is about 3 to 4 hours a week, so it doesn't meet the required amount. Yes, hypoglycemia happened around 87% of our study group experienced hypoglycemia. Most usually it was around 4 to 5 episodes per month, and one responded experienced as many as 15 times per month. Hypoglycemia can occur at any time of the day. Most commonly it happens during the day, but what is important here is that it also happens at night quite often. But luckily, thanks to the real-time continuous glucose, thanks to the systems that alert children when they have low blood sugar, they can wake up and react adequately. So it's not that dangerous now. We can go. Okay. There are many symptoms of hypoglycemia. Most of them are connected to the nervous system, and the ones that happen most commonly to our study group were inability to concentrate, weakness and sleepiness, and hand tremors. Exercise-related hypoglycemia. Around 12% of our study group connect hypoglycemia connect almost all episodes of hypoglycemia to exercise. Usually it was around 30 to 70%. And another important topic is the psychological aspect hypoglycemia has on children. 50% of our study group had a fear of hypoglycemia, and around 50% of them associated with physical activity. I wanted to go back to this graph to highlight some other facts. Of those 57% of children that always take part in physical education, around 59% they stopped participating because of hypoglycemia, and around 10% of children never take part in physical education due to fear of hypoglycemia. As you probably remember, different types of physical activity affect glucose levels differently. So it's significant to consider it beforehand, and it is considered only by 22%. And around 20% don't consider it because they don't think it's relevant, and around 60% say that they don't do it because physical education is too variable to consider it effectively. Okay, and how to prevent it or manage it well. And here, ESPAD released guidelines about appropriate insulin adjustments depending on the type of activity and starting glucose levels. And here's a table for insulin pump users, and on the next is for multiple daily injection users. And as you can see, in most cases, a reduction is needed. Yes, and if it comes to our study group, reduction of prandial insulin before only more than half of our group unfortunately don't reduce prandial insulin neither before nor after physical activity. With basal insulin, situation is a bit better because as much as 80% do reduce it in some capacity before exercising. To sum it all up, hypoglycemia is a really common problem. Around 87% of our study group do experience it. Around 40% of respondents connect more than half of their hypoglycemic episodes with physical activity. And unfortunately, most of respondents don't know the physical activity guidelines recommended for children. And we've reached following conclusions. Despite the importance of physical activity, many children cannot fully participate in PE classes. The proper education on appropriate modification of insulin therapy is vital and needs to be broadened. And we think that the results of our study can support implementation of personalized strategies for dealing with this problem based on ISPAD guidelines. Thank you very much.
Thank you.
Thank you very much. Yes, it was very interesting presentation. May I ask you, do you have this impression that the educational level of the patients are adequate? I mean, do they know what they should do to avoid the episodes of hypoglycemia, and how important is to have physical activity? Do you have the educational level is okay?
I think it's not okay. I think the children, it's out there, but I think it should be broadened, and it should be said to the children that this problem is really important and that they should focus on it. And yeah, because it's a really significant problem. And yeah, to answer your question, I don't think it's enough right now.
And do you have any information of these children? Because, you know, if you have a very small child, you have actually rely on the parents, and with adolescents, well, they are more independent. Do you think that the parents, they are a supportive group and they do understand where is the problem? Or, yes?
You can end the question?
Do you think that the parents are supportive for their children? Do they understand what should be done and how should they deal with the treatment to avoid hypoglycemia connected with physical activity?
Mm-hmm. We actually gave out this survey by ourselves. So we've met all of the children and their parents, and we've talked with some of them. And from what we've gathered, I think they're really supporting. Almost all of the parents accompany children when they go to the hospital, and they seem really engaged in the welfare of their children.
Okay, thank you very much.
Thank you very much as well.
I can't pick up on Jared.
I know. Okay. So thank you very much. Good job. And now it's time for it's time for presentation. The occurrence of diabetic ketoacidosis of the time of first diagnosis of diabetes between 2019 and 2023, presented by Gabriela Gavla.
So, good afternoon. My name is Gabriela Gavlas, and today I would like to present a study entitled The Occurrence of Diabetic Ketoacidosis at the Time of Fresh Diagnosis of Diabetes between 2019 to 2023. My colleagues and I are members of Science Group of the Department of Children's Diabetology and Pediatrics at the Medical University of Silesia in Katowice, where this research was conducted. So during the COVID-19 pandemic, the frequency of diabetic ketoacidosis increased. So we wanted to find out how it looks now. First of all, diabetic ketoacidosis is an acute consequence of diabetes. It's a syndrome involving disorders in carbohydrate, fat, protein metabolism, as well as water electrolyte balance and acid-base balance. It's caused by an acute deficiency of insulin. Based on the International Society for Pediatric and Adolescent Diabetes, we have adapted pH less than 7.3 for the diagnosis of diabetic ketoacidosis, and the severe DKI is defined as pH less 7.1. The criteria also include hyperglycemia above 200 milligrams per deciliter and ketonemia or ketonuria. It's important to know that in very severe cases, DKI can lead to an acute organ failure or even death. So, what are the symptoms of diabetic ketoacidosis? According to the American Diabetes Association, early symptoms include first, or a very dry mouth, frequent urination, high blood glucose levels, high levels of ketones in the urine, and also other symptoms may appear: constantly feeling tired, dry or flushed skin, nausea, vomiting or abdominal pain, difficulty breathing, pretty odor on breath, and a hard time paying attention or confusion. During our shifts in the diabetology ward, we were surprised how many patients were admitted to the hospital in an acute condition. Therefore, we decided to analyze the data from the past 5 years regarding the frequency of ketoacidosis and its severe form. To achieve the goal of this study, we analyzed the database containing medical histories of 943 patients newly diagnosed with type 1 diabetes from each year in the period 2019 to 2023. The patients were hospitalized at the Department of Children's Diabetology and Pediatrics of the Upper Silesian Children's Health Center in Katowice. The diagnosis of diabetic ketoacidosis was based on the criteria of the International Society for Pediatric and Adolescent Diabetes. So let's move to the next point. In the years 2019 to 2023, the annual number of children with newly diagnosed type 1 diabetes ranged between 182 to 197. Compared to 2019, in 2020, there was a significant increase in the percentage of children with newly diagnosed type 1 diabetes who developed diabetic ketoacidosis. That is 29% versus 40% in 2020. The upward trend persisted in the following year as well. In 2021, the percentage of children with newly diagnosed diabetes who developed diabetic ketoacidosis reached 45%. In 2020, it was 40%, and in the 2023, it was 31%. So then I am going to show you how the average pH of patients in the clinic changed over the years. It decreased. In 2019, the average pH was 7.32, and in the following 3 years, it stabilized at 7.29. What's more, in 2023, the average pH was 7.28, which is significantly lower than in 2019. Over the course of the 5-year study period, the proportion of children with severe diabetic ketoacidosis has increased. In 2019, 16 children developed acute ketoacidosis, representing 9% of cases, while in 2023, 31 children developed acute diabetic ketoacidosis, which is 17%. In conclusion, the number of recognized ketoacidosis cases has returned to pre-COVID-19 pandemic levels. However, there has been a significant increase in acute ketoacidosis diagnosis. Therefore, it's essential to increase diagnostic diligence in the context of detecting type 1 diabetes and educate the society about symptoms of hyperglycemia. What's more, it's important to remember that not all children or caregivers may notice classic symptoms of diabetes, like polyuria or polydipsia. And other symptoms of diabetes ketoacidosis are non-specific, making diagnosis challenging. So it's necessary to conduct studies that aim at reducing the incidence of ketoacidosis in children. In the future, in our province, screening tests will be conducted to detect antibodies associated with type 1 diabetes, which hopefully will reduce the frequency of severe ketoacidosis occurrences. Thank you. This is our bibliography, and thank you for your time and thank you for your attention.
Now I would like to invite all of you to ask questions. Our esteemed jury here and online. Do you have any questions?
Thank you very much for your very nice presentation. I would like to ask, what's your explanation for these results? First of all, we have a relation between the increase in ketoacidosis during the pandemic period. So it seems quite obvious, but maybe you have another explanation. But what about the second result? Can you explain that? What do you think?
Okay, so it's a very good question. We thought about it also. And the first thing we thought is that maybe after a pandemic, people were very comfortable with calling their doctors, not seeing them face to face. And as we know, it is very hard for a doctor to give them the proper diagnosis. And also the second thought is that as we know from some studies, the COVID-19 may intensify also some diseases, for example, autoimmunology diseases. So we thought that maybe it can intensify and fasten maybe occurrence of the diabetic ketoacidosis during the diabetes type 1. So yeah, but I think that it's also a good topic to evaluate it in the next study maybe and to see some trends and pattern between this.
Okay, thank you very much. I totally agree with you. Thank you.
Thank you. Okay, thank you. So, thank you. Thank you. Good job. Congratulations. Thank you. Okay, and now Alexandra Kontnik will present work, retrospective analysis of risk factors and clinical course of alimentary tract polyps in children. Dear ladies and gentlemen, my name is Alexandra Kontnik, and today I have a pleasure to present a topic of retrospective analysis of risk factors and a clinical course of alimentary tract polyps in children. The presentation was divided into 5 parts, and in the introduction, I would like to outline what these mysterious structures actually are. They are pathological glandular formations that are growing from mucous membranes and are lined with glandular epithelium. Although they are not always causing our patients a lot of problems, it is vital to remember that they may cause symptoms like diarrhea, constipation, abdominal pain, or rectal bleeding. From a diagnostic standpoint, they can differ in morphology. Polyps can be divided into sessile or pedunculated. It is also very vital to remember to maintain oncological vigilance as patients risk with familial adenomatous polyposis or Gardner syndrome are a therapeutic challenge and require
complex treatment. Differential diagnosis and a proper management of our patients is crucial. So what should we consider when suspecting polyps? Here are a couple of examples. Today, I aim to analyze those risk factors and a clinical picture of those gastrointestinal polyps in children. Our study analyzed 57 patients, 26 girls and 31 boys that were submitted into the Department of Pediatrics and Medical University of Silesia in Katowice between the years of 2014 and 2023. Endoscopic examination serves as a gold standard here and was performed with a removal of those polyps and a histopathological examination. Here are some couple of examples of pictures that we took. So what these 11 years of medical documentation gave us? Well, quite a lot. We got 61 cases of polyps, including cases of multiple polyps. As you can see here, lower gastrointestinal tract was a common location, especially rectum. Furthermore, in the results, not only the abdominal pain occurred mostly in the upper gastrointestinal tract, but also recurrent rectal bleeding and anemia appeared mostly among patients with lower gastrointestinal tract polyps. Interestingly, abdominal pain and mucus in stool were associated with bigger polyps. Lower hemoglobin levels were found to be in lower gastrointestinal tract polyps, and even though the mean score doesn't show it as much, we can see that number of abnormal results as 10 out of 13 patients had their hemoglobin levels abnormal, show us how patients felt their lower hemoglobin levels in lower gastrointestinal tract. Meanwhile, CRP levels were found to be higher in the lower tract. As I mentioned before, lower gastrointestinal tract was a prevailing location, especially among males, as almost 3/4 of our patients had their polyps in lower gastrointestinal tract. When we consider age of our patients, among preschoolers, almost every preschooler had their polyps in the lower gastrointestinal tract, which we found surprising, while among early school children and adolescents, we don't see much of a trend here. Moving on to morphology, the cases that we got were diverse, which we can see much more clearly here. However, I would like to highlight two polyps that stand out: inflammatory and hyperplastic. And when it comes to female population, the inflammatory polyps were far more frequent. When it comes to males, we don't see much of a trend here. Again, when we consider the age of our population, preschoolers and early school children didn't show many tendencies, while adolescents had mostly their polyps inflammatory. We also took into the consideration the size of those polyps. We can see that most of them were below 1 centimeter. And also I would like to highlight here that the male population had their polyps much larger comparing to female population. And during the review of medical documents, we came also to another conclusion. Comparing the symptoms to diagnosis time, it much varied. We can see that abdominal pain was diagnosed much later comparing to lower gastrointestinal bleeding. Well, when it comes to our patients, when they come to us with gastrointestinal bleeding or abdominal pain, I would say it is really worth taking into consideration a presence of a polyp. It is also very vital to observe them and remove, as they may cause much more than just abdominal pain. Thank you.
Congratulations. Thank you for your presentation. Now it's time to discuss. Do you have any questions?
questions. First is you showed materials there were 60 some cases and only 56 patients, yes?
57.
So it means that one patient had
Multiple polyps, yes.
What about genetics? Did you and history? Did you consider the history, family history, and so on, and the genetics? Because it showed that we should be aware of, for example, genetic disorders.
Yes, we took into consideration, especially the family history. And what is interesting here is that the cases with multiple polyps were related to genetics, as, for example, one of the patients got the familial adenomatous polyposis, which is a genetic disorder. Thank you.
Okay. Hazel, do you have any other questions? Maybe our participants, you can also have a question. Okay.
Thank you.
Thank you. And now, please, Natalia Dvorova. She will present her study, the use of programmable shunts in the treatment of hydrocephalus in pediatric patients.
Good afternoon. My name is Natalia Wroba, and I'm here to talk about the use of programmable shunts in the treatment of hydrocephalus in pediatric patients. To start with, hydrocephalus is the most prevalent neurosurgical condition among children, which is caused by the disruption of normal cerebrospinal fluid flow dynamics, resulting in abnormal enlargement of ventricles. Signs and symptoms of hydrocephalus may vary with age and can include macrocephaly or sensitive eyes. However, above the age of 2, symptoms of intracranial hypertension are more frequent. Treatment methods differ based on multiple factors. However, here are 3 main ones: temporary management like external drainage, endoscopic third ventriculostomy, and cerebrospinal fluid shunting, which is considered to be the golden treatment standard for hydrocephalus in current practices. The role of the shunt is to remove the excess cerebrospinal fluid from ventricles to body cavity like peritoneal cavity or pleura, and the shunt usually consists of the proximal catheter and the valve and the distal catheter. In most cases of hydrocephalus, differential pressure shunts are used, and they rely on the pressure change difference between the proximal and distal catheter. And there are 3 main types of this shunt: low, medium, and high pressure. However, our study is focused on programmable shunt, which allows the neurosurgeon to adjust opening pressure settings non-invasively in post-operative period if it's necessary. The aim of this study is to analyze the use of programmable shunts in the treatment of hydrocephalus in pediatric patients with focus on indications and treatment outcomes. It's a retrospective analysis of patients who underwent implantation of programmable shunts to the Department of Pediatric Neurosurgery in Katowice between 2013 and 2023. If it comes to a study group, after analyzing 1,162 procedure records of patients with non-tumorous hydrocephalus, we selected 66 individuals with programmable shunts. And males make up 56.1%, females 43.9%. The youngest patient was 2 months old and the oldest 17 years old, and the mean age was 5.3 years.
27 patients had programmable shunt implantation as a de novo procedure, whereby 4 of them had prior failed ETDs, and in 39 cases, programmable shunt was implanted secondarily to the breakdown of the previous shunt. Indications for programmable shunt implantation were significantly enlarged ventricular system, 34.8%, over drainage, 28.8%, multiple shunt dysfunction, 13.6%, and 1 patient had Danto-Walker syndrome. In other indication, we included post-traumatic and post-hemorrhagic hydrocephalus, or simply congenital hydrocephalus with no other data. The need for revisions occurred in 37.88% of patients, and 4 of them needed to have anti-siphon device implanted. The main reasons for revisions were shunt malfunction or catheter blockage or shunt migration. Less than half, exactly 42.4%, of patients required reprogramming of the shunt, and 13 of them have their opening pressure settings changed more than once. The mean number of adjustment per programmable shunt was 0.82. We also noticed that patients with a secondarily implanted programmable shunt required adjustment of the opening pressure settings 2.4 times more often than those with a de novo shunt. To sum up, the programmable shunt placement is not only safe but also valuable method for treating hydrocephalus in children. And the main indications for programmable shunt implantations are over drainage and significantly enlarged ventricular system of the brain. In the majority of patients with a programmable shunt implanted, de novo post-operative adjustments are not necessary, and initial 3 sets are usually sufficient. And last, patients with a secondarily implanted programmable shunts require reprogramming more often than those with de novo shunts. Thank you.
Thank you for your presentation. Now it's time to ask questions. Any questions? Is there online or here? Okay, our audience have a question.
I would like to ask you why don't all the patients have programmable shunts to avoid another operation?
Programmable shunt is a valuable tool for treating hydrocephalus. However, there are some disadvantages of this shunt. For example, programmable shunts are bigger than DPS shunts, which are usually used, so they are more visible. And also, another disadvantage is that the opening pressure settings may be changed by magnetic interactions, so they may be changed non-intentionally by child by playing with magnets. That's all. Any other questions? Thank you.
Okay, so thank you. Okay, and at this point, as I said earlier, I asked the committee to move on to the evaluation of the work number 8. Surgical treatment of spinal lymphomas in pediatric patients by Patrick Stabrava.
Ladies and gentlemen, I'm Patrick Stabrava, and with Alexander Tutela, we prepare a presentation about surgical treatment of spinal lymphomas in pediatric patients. So what are spinal lymphomas? Spinal lymphomas are the most common malformation in pediatric neurosurgery. They are found among spinal dysrhabism and frequently associated with spina bifida. Basically, spinal lymphomas form during neurulation. But what the neural lesion really is? Neural lesion can be divided into two processes, primary and secondary neural lesion. The aim of both of them is to form the neural tube. Primary neural lesion involves the process of folding the neural plate into the neural tube and ends with the closure of posterior neural foramen at 28th day or after fertilization. With secondary neural lesion, there is an intense mitotic division of caudal eminence, and then its creation of a cavity that will form a spinal cord canal in the future. So, embryonic background of spinal lipoma is marked by premature disjunction between cutaneous and neural ectoderm. Failed primary neural lesion allows invasion of mesenchymal tissue into the neural structure, and then the spinal lipoma is created. There are some different classifications of spinal lipomas. The most recent one is Morota's classification that is based on the embryonic stage. There are 4 types of lipomas that can be distinguished using MRI scans. The good indicator of the type of lipoma is conus medullaris location. In type 1, conus medullaris is located distally or ventrally with respect to the caudal eminence. In type 2, there's the conus medullaris is malformed and it's hard to recognize on MRI. On type 3, there is a presence of conus medullaris, but the caudal end is unformed, it directly connects to the spinal cord. And spinal in type 4, the spinal lipoma is located in the filum terminale. What is the treatment? Basically, we have 2 steps in the treatment of spinal lipomas. Removal of the lipoma and antegearing of the spinal cord. In type 1, there is the radical resection is possible because there is a fusion line, and it's quite difficult, the type 1. The type 2 is the hardest to operate because there is no fusion line and the conus medullaris is malformed. Type 3 is easier one, but not that difficult. And type 4 is the easiest one because all you need to do is just untether the spinal cord and that's it. There's some asymptomatic patients in our group. So there are 2 approaches to treating asymptomatic patients. First of all, we can do surgery due to our risk of developing symptoms. And another group says that we should refrain from surgery because of possible postoperative complication. It's around 30%. So the aim of our study was to analyze the indication for the surgical connection, as well as clinical outcomes and complication of the treatment. Material and methods was a retrospective analysis of children treated for spinal lipomas in the Department of Pediatric Neurosurgery in Katowice between 2012 and 2022. Study populated 32 girls and 19 boys, included 51 patients, and average age of patients was 3 years and 11 months. The most common symptoms was birthmarks, paraparesis, neurogenic bladder. Asymptomatic was 11 patients, but what I have to say that birthmarks in some patients was the only symptoms, and considering it's not a severe one and doesn't particularly interfere with life of these children, we can say that it's kind of like asymptomatic patients, what will be important in later part of presentation. Types of spinal lipomas. We have 25 of type 1, 14 type 2, 5 type 3, and 7 of type 4. What's interesting, it turned out that the perioperative complication like leukorrhea or infections occurred exactly as the difficulty of the operations. So with type 2, we have 50% of perioperative complications, and with type 4, we have least with only 14% of perioperative complication. Operation included 16 radical resections of spinal cord and 35 partial resections with untethering of the spinal cord. Early outcomes. So right after the procedure, it turns out that in most cases, clinical status of the patient doesn't change. What we expected, because we didn't expect to get to improve or to get worse. Follow-up shows that 9 patients improved, 20 not changed, and 10 worsened. And that's a good outcome because we didn't expect that the patient will improve itself after some time that much, and it's not like the clinical outcome of a patient, if not changed, it's not like it's bad or something. So our conclusion is that surgical treatment can be performed in symptomatic patient or as a prophylactic management. And in our patient, surgical management of spinal lipomas turned out to be a safe and effective procedure. Thank you very much.
Thank you for your presentation. Anything to discuss? Any questions? Okay.
Thank you very much for your presentation. It's very interesting. However, I'm very surprised that only in 96% actually there is no change in the patient's condition, and also in the long-term follow-up. So what is the main reason for the surgery? Is it a cosmetic reason also, or we are afraid of further long-term consequences? And if so, what can it be?
Yes, as I said before, there is 30% in asymptomatic patients that they can develop new symptoms in 10 years. So if we have only 25% that symptoms worsened, it's not even like they get new symptoms. It's just the symptoms they already had just worsened objectively. So yeah, that's better. That it's not that much, because in 10 years there's 30% of chances to develop symptoms, new symptoms that didn't occur before.
Okay, thank you.
What is the best time for surgery?
It's hard to say. There's not much data about it, but the thing is that if the spinal cord is tethered and the children grow, the spinal cord can't go higher. It's still on L1 or L2, and it should be on L6. So the best time is before the children growing, you know.
You mentioned tethering. What does it mean?
Okay, I can answer the question. So tethering is basically the condition in which the spinal cord is attached to, for example, in our cases, to the lipoma. This is really serious condition, as my friend said, because as the children grow, that can cause the spinal cord to stretch out, and this can lead to pain, to destroying the spinal cord and other symptoms. For example, the progressive scoliosis, and yes, that's the answer.
So thank you. We are running out of the time, so
Okay.
thank you.
Thank you very much.
And now it's time for a ninth presentation of today's session. I would like to invite Marta Hrabek to deliver a paper, characteristic of pediatric patients with hepatic steatosis, single center study. Good morning, dear colleagues and jury. My name is Marta Hrabek, and I'd like to present our paper about the characteristic of pediatric patients with hepatic steatosis. As quick introduction, hepatic steatosis is a progressive disease of the liver, and it occurs when 5% or more of hepatocytes contain fat deposits. It leads to the fibrosis of the liver and can progress into cirrhosis and hepatocellular carcinoma. Our study aims to evaluate the clinical picture of the pediatric patients with hepatic steatosis hospitalized at the Department of Pediatrics and Pediatric Gastroenterology Outpatient Clinic in Katowice. We retrospectively analyzed the patient data from last 6 years of 100 patients that were diagnosed using ultrasonography scans. We examined 100 patients, of which 72% were boys and 28% were girls. 84 of our patients were obese, 13 were overweight, and 3 had normal weight, according to the BMI charts. 86% of our patients, the vast majority, had other coexisting diseases outside of hepatic steatosis. The most prevalent one was obesity, but hypertension, hepatomegaly, hypothyroidism, autism, and epilepsy were also present. We analyzed lipid and carbohydrate metabolism markers and also liver damage parameters and cholestasis parameters. The average age of diagnosis was almost 13, but somewhere as young as 4, spanning to 18. Our study showed that the average BMI is 30.65, which indicates obesity in the majority of our group. Alanine aminotransferase and aspartate aminotransferase were slightly elevated. It's worth noting that the insulin levels were incorrect in 77.5% of our group. We took a closer look at lipid metabolism of our patients, as presented on the graphs with the distribution of BMI. 65 of the patients had 1 or more lipid abnormalities, and 59% of them had elevated total cholesterol levels. The LDL cholesterol was raised in 41% of the cases, and triglycerides in 26% of them, which generally go higher with the higher BMI. 23 patients had HDL cholesterol under the normal range, which generally decreases with higher BMI. It's noteworthy that lipid abnormalities correlate with high cardiovascular risk. Moving on to liver markers, we found out that the best laboratory indicator is AST to ALT ratio below 1, which most of our patients had. As looking at the graphs, we can see that the higher lipid concentration correlates with lower AST to ALT ratios. Looking at the body composition analysis, we can see that the percent of the fat on the trunk, around 43%, is similar in all children who participated. It is a great tool and will be especially useful in the group with normal body weight. Special attention should be paid to the group with normal body weight. Although it's small, their AST to ALT ratio is a lot lower than in all other examined groups, but they have better lipid metabolism markers. Hypothyroidism is linked with slower metabolism, higher cholesterol levels, higher AST levels, and is one of the risk factors for metabolic dysfunction-associated fatty liver disease, which we can see reflected in the lab results of our patients. Over half of the children were assessed using FibroScan, and the results are higher in the fibrosis group than in other children. It's noteworthy that FibroScan is a great tool for fibrosis progress assessment, but not for early diagnosis of metabolic dysfunction-associated fatty liver disease. Hepatic steatosis is a disease that in itself heightens the risk of, for example, cardiovascular disease, but it can also progress into conditions with much more severe clinical implications, which we can unfortunately see in our group. 100 of the examined group has metabolic dysfunction-associated fatty liver disease, and 14% of the examined group has fibrosis of the liver, and no one, thankfully, has cirrhosis of the liver. But they are all put on a higher risk of developing it later in their lives. In conclusion, overweight and obesity are primary risk factors for metabolic dysfunction-associated fatty liver disease. The second one is lipid abnormalities, and AST to ALT ratio should always draw our suspicion to metabolic dysfunction-associated fatty liver disease. And patients with normal body weight should be diagnosed in depth and require special attention. Thank you for your attention, and I would like to invite my colleagues.
Thank you for presenting your work. Christine, Julie, do you have any questions?
Thank you for your presentation. I have one question. You have mentioned this parameter AST to ALT ratio below 1. I don't understand that it's not routinely measured. I mean, AST and ALT we do measure, but the ratio is not routinely calculated. Am I right?
I think it's considered in the diagnosis, but the main diagnostic criteria is ultrasonography scan.
Okay. So do you think that during I'm just wondering if it's possible to do this test in the outpatient clinic when we have, for example, obese child? So do we have to consider this in the diagnostic procedure, this kind of tests?
Some of the patients were from the outpatient clinic, and they usually have their blood drawn in the morning, and later they have their appointments. So it's possible to use this AST to ALT ratio.
And the majority of these patients you have evaluated in your project, they were patients hospitalized in the unit or in the outpatient clinic?
I think the majority were hospitalized.
Yes.
Okay, thank you.
Thank you very much.
I was just wondering, what about the vitamin D level and about hyperuricemia? Because as you know, obesity and the problem of liver, you should consider hyperuricemia as well. The level of
not all of the patients have had uricemia and vitamin D measured, unfortunately.
how many of them? Is it just the routine,
Only I think some of the hospitalized ones had, but not all the patients, we couldn't consider it.
Do you know the definition about these two disorders? Because steatosis of hepatitis has the diagnosis, because you told us that the main diagnosis is based on ultrasonography scan. It's true. But afterward, you need the parameters aspat and alat. Why? What's the difference between this?
Because we have to consider the inflammation of the liver.
Yes, right.
And all the patients had other diseases like Wilson or inflammation of the liver ruled out. So we didn't consider them in our study.
Yes, that's true. But still, there are two different groups, just only with, first you have to do ultrasound scan. Okay. And next you will find these two groups, one with inflammation and which are going to this metabolic disorder, and one without, at the first stage of steatosis of liver, but not with the metabolic chronic disease. You know, that's the problem. When the aminotransferase are going up, when they are increased, you have the inflammation.
So I'm sorry to run out of the time, but thank you, Korea, for the discussion. Okay, I would like to present the paper MPS Fast Track Diagnosis and Treatment Consequences by Julia Ślążak.
Good afternoon. Today I would like to present mucopolysaccharidosis that are treated at the Upper St. Legion Children's Health Center. We will be focusing on the two types, mucopolysaccharidosis type 1 and type 2, and they are considered rare genetic disorders. Because what happens here is we have an enzyme deficiency. In MPS 1, we have alpha L iduronidase, and in MPS 2, we have iduronate 2 sulfatase. What happens here is we have dermatan sulfate and heparan sulfate that kind of do not get degraded, and they are left out in tissue, which causes various symptoms. The epidemiology is not very frequent because it is approximately 1. Here we have 1.81, but I found in literature values that it can be 1 per 100,000 live births. And the aim of this study is a little different because once we actually looked at literature and we looked at the data we collected, we decided that instead of looking at diagnosis and treatment that we have written in the abstract book, we will look at clinical symptoms because this is, for us, more interesting to look at in terms of the presentation. For the methods, we had 6 patients, and the data range was from 2009 to 2024. We evaluated the age of diagnosis, anthropometric measurements, morphological blood indicators, clinical signs, as well as imaging findings. So for the patients, here we can see an image of an MPS 2 patient. He was the only patient out of the 6 that had MPS 2. He is unfortunately not treated in Katowice anymore because we are not under the program for the treatment, so he's treated in Krakow. But essentially, as a summary, we had 1 patient as well that was the second diagnosis in the family, and 1 patient is still being treated at the Upper St. Legion Children's Health Center because he was not qualified for hematopoietic stem cell transplant in Wrocław due to the fact that he is too old, because he is 16. And here we have the patient that I just mentioned. So as you can see here, he has some clinical symptoms. So he has a large mouth. He has a pretty large face overall. He had also had cataracts. And he underwent corneal transplantation in both eyes. What else is important for this patient is that he has a very short stature. He is nearly 17 years old, but really he looks like an 8-year-old patient. He also has joints that are not properly formed, and his left lower limb is actually shorter than his right lower limb. So here we have a summary of the blood parameters and the development of the patients. So this is really what led to their diagnosis. In summary, the developmental stages were correct in 3 out of the 6 patients. So at the beginning, the parents wouldn't even suspect that the patient could be sick. But later on, we have shown that there has been some retardation, or even the children actually went backwards in terms of development. What is important here is that patient number 6 is the patient with MPS II, and that is why alpha L iduronidase levels are okay, because he has 8.4 with a cutoff value 1.5, but he was lacking the MPS II enzymes. The symptom prevalence, so as mentioned already, correct development in 3 out of the 6 patients. We've divided them into different categories. So we had osteoarticular symptoms, ophthalmological symptoms, laryngological symptoms, and abdominal symptoms. What is important here is that the symptoms are different. So it wouldn't be possible to statistically measure every single symptom because most of the children have different symptoms, except in terms of cardiac symptoms, and that is why. Oh yes, and actually before I go. So here's another patient. This patient has already undergone hematopoietic stem cell transplantation. But what is important here, what hasn't been shown in the previous patients, is the umbilical hernia, which is also a very common feature of mucopolysaccharidosis, and as well here with the joints. And they also have carpal tunnel syndrome. So the previous patient also had carpal tunnel syndrome. Because cardiac symptoms were the most prevalent, found out in 5 out of the 6 patients, which is actually for MPS I, all of the patients have shown cardiac symptoms. The most common one was mitral valve insufficiency, which has been shown as mitral valve regurgitation. The next one was tricuspid regurgitation and aortic valve regurgitation. What is important to note here is that the MPS II patient actually didn't show cardiac symptoms, but I would like to highlight the fact that we haven't seen him for over a year now. So he is treated in Krakow, and therefore maybe due to the natural disease progression, he might already have developed cardiac symptoms, but according to literature, MPS II patients don't have cardiac symptoms as often. For the imaging, because magnetic resonance is performed in those patients as well as a control, all 6 presented Sella-Turcica distortions. 5 out of the 6 patients presented delayed myelination. And what is important is that, according to the disease progression, 3 of the older patients actually presented vertebral body deformity, which wasn't found when they were smaller children. And here we have a summary. So we have 2 patients that have undergone a magnetic resonance as a control. Patient number 3 is actually a patient that has underwent the hematopoietic stem cell transplantation in December. So we don't know how the symptoms changed from that point because there hasn't been a control yet. But despite that, they were all treated with enzyme replacement therapy. And as you can see from the start, they still show new symptoms. So even though they had the therapy, we couldn't stop the development of the disease completely. And now for the conclusion. MPS symptoms onset occurs in the first months of life. And what is important here is that we have early diagnosis that is crucial for treatment qualification, because as with the 16-year-old patient, he cannot have hematopoietic stem cell transplantation due to his age. Early enzyme replacement therapy alters the disease course, but we can never guarantee, as we've seen in the magnetic resonance imaging, that we will actually stop the onset of the disease. And treatment doesn't completely stop symptom progression. While the hematopoietic stem cell transplants, we didn't look at those patients because they are in Wrocław, and this is actually, we'll try to write an article regarding those patients, and that is why in this presentation we skipped them. What is important to note is that for MPS treatment, we also have gene therapy, and this gene therapy should be better because it will make sure that we have supraphysiological enzyme levels, and then the degraded heparin and the dermatan sulfates will actually not stay in the tissue. Thank you for your attention.
Thank you for your presentation of your study. Let's start the discussion.
Thank you very much for your presentation. I have such a question. As I'm a neonatologist, I'm mostly interested in the very early period of life. All these patients were diagnosed in a quite early time of his life, but do you have any information about the neonatal period? I think about any symptoms that were suspicious, and that's why the process of diagnosis were initiated early enough? When was this point that the doctor sent the patient for the diagnosis and thought about MPS?
So we didn't have data exactly regarding this, but we did have data regarding the pre-birth condition of the mother, and all of the mothers were healthy. One thing for one of the patients, because her sister is also sick, so in this case, that is what prompted the diagnosis that was quicker, and therefore she is already after the hematopoietic stem cell transplantation. But for the rest, I think it was mostly due to the delayed development, and that is the stage where they actually started to diagnose for this.
Okay, thank you very much.
Okay, so thank you very much. Congratulations. Okay, I would like to ask to present the paper Clinical Picture of Patient Diagnosed with Gilbert Syndrome, Single Center Study by Natalia Leszczyńska.
Ladies and gentlemen, my name is Natalia Leszczyńska, and I would like to present a single-center study about the clinical picture of patients diagnosed with Gilbert syndrome. Is Gilbert syndrome only a mild disorder? It is characterized by mild hyperbilirubinemia, affecting 3 to 12% of the population. In recent years, a number of risks, such as drug interactions and the occurrence of gallstones, as well as benefits such as lower cardiovascular risk and cancer, have been demonstrated. The aim of the study was to assess the clinical picture of pediatric patients diagnosed with Gilbert syndrome. The retrospective analysis concerned 83 pediatric patients with Gilbert syndrome. 52 of the patients were boys and 31 were girls. The average age at the diagnosis was 13 years old, and the average BMI was 20.38. We have used the percentile grids to assess the obesity problem. Nearly 80% of the patients presented symptoms. The clinical picture was dominated by jaundice of the skin and sclera and chronic abdominal pain. As we can see some correlation between symptoms and the age of the patients. Older children reported jaundice and abdominal pain, and the younger ones had vomiting more often. The average reticulocyte count was 1.63%. The hematological diseases occurred in 3 of the patients, and the 2 of them had hereditary spherocytosis. And hyperbilirubinemia may be exacerbated when the hemolytic anemia and Gilbert syndrome are concomitant. However, our patients are still during the diagnostic process. And 37 patients between 10 and 15 years old have had the most elevated average total bilirubin level, which so we can presume that during the adolescence, Gilbert syndrome is diagnosed more often. However, we should not ignore symptoms earlier, because 9 patients below 10 years old were diagnosed in our clinic. Also, for the p-value less than 0.05, we presume that younger children have lower average level of total bilirubin than the older ones. Gilbert syndrome doesn't lead to cirrhosis and liver failure, but is it really just about beauty? Ultrasonography showed 30 patients with abnormalities, such as hepatomegaly, splenomegaly, and hepatic steatosis. These patients had elevated enzymes in blood tests. However, they're still on the diagnostic process. And here are presented some of the comorbidities found in our patients during and after the diagnosis. Many studies prove that the UGT1A1 gene mutation increases the risk of cholelithiasis, and 9.6% of our patients had concomitant gallstones. The lifespan of red blood cells in Gilbert syndrome patients is shortened by 30%, which leads to prolonged neonatal jaundice and a more severe course of hemolytic diseases. 2.4% of our patients had prolonged jaundice. Some drugs can have a suppressive effect on UGT1A1 gene expression or can compete with bilirubin for the UGT1A1 enzyme. In both cases, it can lead to potentially toxic side effects in Gilbert syndrome patients. The hypersensitivity occurs in anti-cancer drugs, antiviral agents, statins, and non-steroidal anti-inflammatory drugs. Stress and physical activity may worsen symptoms. However, due to improper diet and the 7.2% of obese patients, we should not excuse children from participating in PE classes. 6% of our patients have had a confirmed diagnosis of Gilbert syndrome among family members. However, is it necessary to test all the patients? The diagnosis can be made by a clinical picture and laboratory test results. However, 24% of our patients had genetic testing, and all of the tested patients had UGT1A1 gene mutation. Bilirubin reduces oxidative stress and has a vasodilation effect on blood vessels. Patients with Gilbert syndrome have lower risk of cardiovascular diseases. However, luckily, our patients are too young for this. In conclusion, Gilbert syndrome causes mild symptoms. However, it is important to remember that other diseases may often coexist with this syndrome, like hemolytic anemia or gallstones. Moreover, the drug sensitivity is more frequent than in a population. Thank you very much. Invite you to the question. Okay. Thank you for presenting your work. Julie, do you have any questions?
I have a question about the study group. How many of them were obese?
7.2% of these patients, yes.
Is obesity correlated to steatosis? Hepatic steatosis?
Yes.
Because you all say that is the consequence of Gilbert syndrome, maybe because of obesity. Yeah. So maybe the other question. How many children with liver disease, with the steatosis, were obese?
All of the patients, all of the patients which were diagnosed with hepatic steatosis were obese. So yes. Okay. Any other question? I didn't see. So thank you for your work, for your presentation. Thank you very much. Congratulations. Okay, and now it's time to present the last papers today's session, number 7. Has the representative of this work already reached us?
Yes. Oh, okay. There you are. Okay, so it's time for you. Pediatric chronic kidney disease in the era of COVID-19 and migration.
Good morning. My name is Paulina Tomecka, and I represent Student Scientific Association at the Department of Pediatric Nephrology. I would like to present the topic Pediatric Chronic Kidney Disease in the era of COVID-19 and migration. To begin with, chronic kidney disease is defined as a condition that lasts for more than 3 months and meets one of 2 criteria. An estimated glomerular filtration rate less than 60 milliliters per minute per 1.73 square meters, or the presence of kidney damage, which can be indicated by abnormalities in blood or urine tests, imaging studies, or histological findings, regardless of the eGFR level. Chronic kidney disease is stratified into 5 stages depending on the estimated glomerular filtration rate. Detecting this condition early can pose challenges as it frequently progresses without noticeable symptoms during its initial phases. Anemia typically arises when the GFR falls below 50 milliliters per minute. The etiology of CKD in children includes congenital anomalies of the kidney and urinary tract, genetic disorders like polycystic kidney diseases, congenital nephropathies, glomerulopathies, and other reasons, including acute kidney injury. The aim of the study was to retrospectively assess clinical data from pediatric patients with CKD at the Department of Pediatric Nephrology in Wrocław. Comparative analysis spanned 2 5-year periods. The study analyzed the etiology of CKD, the stage at the diagnosis, and the occurrence of anemia in relation to the patient's age. Our study group consisted of 175 patients. During the years 2014 to 2018, the number of children diagnosed with CKD was higher than in the next period, and this advantage applied to all age groups. In both time periods, children over the age of 10 were most numerous. CKD was more frequently diagnosed in boys. Next slide, please. As demonstrated in the diagrams, congenital anomalies of the kidney and urinary tract were the leading cause of CKD across all age groups. The amount of genetic disorders was higher in 2019 to 2023 than in the previous period. Next slide. Moreover, the incidence of unknown causes of CKD increased with the age of the children. In the group over 10 years old, it accounted for 22% in the first time period and 24% in the second time period. Next slide, please. In 2014 to 2018, the majority of patients was diagnosed at the early stages of CKD, mainly due to the efficient and relatively early diagnosis on congenital anomalies of kidney. Less than 20% of children was first admitted at 4 to 5 stages of CKD, whereas in the next period, late diagnosis concerned over 30% of patients. The percentage of patients with anemia at the time of diagnosis has increased from 25 to 36% through the observation periods, although this difference wasn't evident in every CKD stage. Based on the obtained data, we drew such conclusion. Next slide, please. The modern diagnosis tools improve identification of genetic diseases, becoming the second most frequent causative factor of CKD in children. The pandemic and migratory condition may have restricted admissions to pediatric nephrology departments in due time, thus delaying the diagnosis of CKD. The latter could add to the significant precipitation of unknown causes of CKD, the highest among adolescents, identifying them as a group most susceptible to late CKD diagnosis. And that's all. Thank you very much.
Thank you for your presentation. Any questions?
Thank you very much for your presentation. I have one question. These differences between you showed between these two subgroups, the differences were statistically significant or not?
Yes, it was significant.
Okay, thank you.
Do you have any idea about the policy, how to stop the increasing trend of disease?
Could you repeat, please? We
have any idea how to stop this increasing trend? Can we do something?
Okay, hello, can you hear me? Excuse me, can you hear me right now?
Yes, we can.
Okay, so to answer this question, we must clarify that the CKD progression is unstoppable and we cannot prevent such degradation. We can only slow this by early diagnosis and work and treatment of base disease, which lead to CKD.
So, thank you for your presentation.
Thank you.
Okay, so all the submitted papers have been presented. We congratulate all of the presenting authors and participants of the neonatology and pediatric session. At this point, I would like to ask the president of the jury for a few words to sum up the session. Yes, sir?
So I would like to thank you all presenters for such really hard work and just to take the challenge of be at the stage.
Dzień dobry. Zobaczyłem na stronie internetowej, że tutaj jedynie w tym sklepie są dostępne rękawiczki do wspinania się w rysach od Black Diamonda. Od razu bym chciał przypomnieć.
So please use it. So I think we learned a lot.
Sorry. Technical problems.
We learned a lot together, and now it's time for Ivona and me to score the presentations. Thank you so much.
Professor, thank you for this word. Thank you to the entire community for their time, and also thank you, Professor Ivona, for being with us online.
Thank you very much. It was a great pleasure.
Thank you very much. We would like to cordially invite you to the decoration and closing ceremony of the SIM 2024 conference, which will be held in Theatre Rialto on the 17th of May at 6 p.m. tomorrow. Yeah, that's all. On the behalf of the Student Society, Scientific Society, I would like to thank you. Thank you all, and congratulations to your wonderful and interesting works. And see you next year at the SIM 2025. Thank you very much.
Thank you very much. Bye.